Okay. So the recording is on now. So if anyone of you have any kind of question, you can either raise hand and type in the chat. We will have 10 to 15 minutes in the end, exclusively dedicated to the questions part. So you have to bear with me for a while. What I planned to do with this presentation, I wanted to go through the CT image acquisition and CT image interpretation, and then we would have moved on to the MRI images and the sequences and the interpretation. But I got few messages from the people that really wanted to go through the MRI. So I just thought that we will focus on the MRI first. Then if we get the time and the energy to do the CT part, then we'll come back and do the CT imaging. So let's start with the MRI first. It's really important imaging, especially in the neurology and neurosurgery. So before going on to the different image sequences of the MRI, you really have to know how the different MRI images are created, how we obtain these images. I won't go into really in the really deep details of imaging of the MRI, but there are some things that you have to know to understand the different sequences of the MRI. First, you must know that the MRI stands for magnetic resonance imaging. So there has to be some kind of magnet in the whole scenario. So there are two kinds of MRI machine. You must have seen those in your setups. The one is the open MRI, the other one is the closed one. You can see on the right side, this one is a closed MRI machine. The other one is an open MRI machine. But what is this machine? This whole machine is a large, big magnet. It has a certain strength, which you must have heard that this is a 0.3 Tesla machine. This is a 1.5 Tesla machine or 3 Tesla machines. There are other higher power machines as well, like 5 and 7 and 11 Tesla, but they're mainly used in research purposes and not routinely used. Even Pakistan has a very few 3 Tesla machines. Most centers have only 1.5 Tesla machines. So what happens inside these machines, how the images are created. So we have abundance of hydrogen atoms in our body. Every hydrogen atom has a single proton. It's the nucleus, so it's basically a positively charged particle. Now, every proton or positively charged hydrogen at nucleus, what it's doing is continuously spinning around its own axis like this. It has a spin. Apart from spinning, it wobbles around axis, just like a spinning top that you must have seen in the Inception movie. The totem in the end, it keeps on wobbling around in an axis. So what happens when a positively charged ion or nucleus moves in a field? It creates its own electromagnetic field. Whenever a positively charged, negatively charged particle moves, it creates its own electromagnetic field. That is a factor that is being utilized in an MRI to create the images. Now, we have abundance of these charged particles in our body. Normally, and in a net neutral condition, all these nuclei are moving randomly in all different directions. So net effect on our body is a zero magnetic or electric effect. We don't have any magnetic charge or any magnetic field. But when we place the body in a very strong magnetic field, all these hydrogen atoms, most of these align towards parallel to this, the magnet that we place it in. The very few align opposite. They tend to remain the lower side of the energy. The most abundance of these atoms align themselves along the magnets. This happens when you are lying in the machine of an MRI. Then what we do, then we this is just like a patient lying in a machine. The B naught is the strength of the magnetic field, and its axis is taken by default as Z axis for the purpose of convenience. What we know through the physics, that every hydrogen atom that is spinning at a particular frequency. This is called Lemore frequency. We have calculated that with an equation. So if we give an energy pulse to these atoms in the body at a particular frequency, we can control the frequency of the energy pulse that we are giving to these patients. Some of these hydrogen atoms will start spinning in a different direction. For example, it is spinning in a Z direction, it will absorb the energy and will start moving towards y-axis when it has taken the radio frequency pulse that we externally gave it to it. But when we remove that pulse, what happens? All the things have a tendency to go toward the lower energy state. We know that because of our very basic knowledge. All the things now need to go towards the lower energy side. So it goes back to its normal side. And what it does when it goes back to its normal side, uh, normal axis, it releases the energy it absorbed. It releases back. This is the energy that we detect with the help of a detector, and then we use that to create an image of the MRI. This is a graphical representation of the same thing that I just showed you, that all the things were aligned along an axis. When we gave it an external energy pulse, it realigned itself along a different axis. And then when we removed the energy, it came back to its normal area and released back the energy. This is the energy that we will again see to calculate the images. What happens, how the different parts of the bodies are imaged, that although they are all hydrogen atoms, but when they are in a different part of the body, they release the energy back in a different manner, in a different time. You must have heard in the MRI there are T1 and T2 weighted images. These T1 and T2 are the times when the radio frequencies that are received back. T1 is the time then when about 63% of the energy given back is received by the detector. Now, the molecules in the fat, they release their energy really fast and they have very T1 shortened time. You must have heard this term that fat has a short T1 time in comparison with the CSF, which has longer T1 time. I'll come back to this, what its significance is when we will talk about sequences. Similarly, the T2 weighted images, they have a different significance. They are taken as a frequency pulses, they can at a different time. Then there are some other parameters of the MRI as well, like gradient and phase encoding, gradient encoding, phase frequency coding. All that physics needs to be need like 3-hour long lecture to be completely explained. But for our sake of this lecture, this much information is enough, and you will totally understand the sequences based on this information alone. You can just assume that all the signals we receive back, some kind of sci-fi magic happens, and the image is created by placing on a different voxel. Every single part of the body is giving back an image of a different intensity. It's a very high intensity signal. It will be placed as a white. It's a low intensity. It will be placed as a black area, and soon you will have a whole image created pixel by pixel. If anyone of you have worked in a Photoshop or photo editor or video editor, you must know the kind of pixel by pixel creation of the images. The same things happen, but instead of pixel, it's a voxel, because we don't have a two-dimensional image, we have a three-dimensional image. So apart from getting an X and Y axis, we also get a Z axis of the image as well, and the whole image is created as well. Now coming to the sequences of MRI. There are few sequences in the MRI of neurology or MRI of the brain only. I will just enumerate those, like there's T1, there's T2, there is flare, there's DWI, there is ADC, there is SWI, contrast enhanced T1, MRS, PDW, tractography, which is a really colorful imaging of the different white matter tracts, and perfusion imaging, again, which is a very colorful part of the radiology, contrary to the common belief that we deal only in black and white images. So it's really overwhelming kind of thing that we have so many sequences, what to look for, a way to start. So whole purpose of this presentation is to make it easier for you to understand sequences and to see what kind of information we can get from different sequences. So we'll break down these sequences, the different images, into 5 major groups. This is just the basics. We'll have T1 and T2. We will have diffusion weighted imaging. We have susceptibility weighted imaging, which is also called as SWI imaging. We have some flow sensitive images, and then we will talk about few miscellaneous. I have omitted a few actually, which won't concern a neurologist or physician at the moment. So let's start with the T1 and T2. I have already told you that the T1, T2 time name is given based upon the time at which the signals are received from received back from the human body inside the machine. Some really pedagogical professors will tell you to look at the TR and TE time. Whenever you see an image of an MRI of any part of the body on a film or on a console, you will see there will be mentioned TR and TE time somewhere in the corner here or here or here. It will be mentioned somewhere. So there's a way to recognize the T1 and T2 waiting time. That T1 have short TR, TE time. TR stands for recovery, and TE stands for echo time. The echo time will give the radio frequency pulse, and during the recovery, we'll see it back. So this is the time during which the radio frequency pulses are given and taken back. Similarly, the T2 weighted images will have a mentioned TR, T2 time. TR is usually more than 2,000 milliseconds, and TE is really more than 45 milliseconds. But it's really cumbersome to memorize these. And sincerely, if you don't have enough time to look at the corner, see, decide if the TR time is high or low, especially the professor is standing right next to you and asking you to interpret the images. So we have a really rule of thumb to identify the different sequences based on the images alone. So T1 is the first image of the MRI. So being the first, it remains true to the anatomy. What it means that in the T1 weighted images, the white matter will remain white. It remains true to its anatomy, and the gray matter will remain gray. You can see here there is the cortex. It appears gray, and the underlying white matter in a fungating or infiltrative manner appears white. You have had the correct nucleus with the gray matter lying deep within the white matter. It appears gray relative to the internal capsule, which again is appearing white. Again, you can see external capsule, insular cortex again is appearing gray. And second most important thing, the CSF will be always dark on T1 weighted images. It holds true for all the body. The fluid will be dark on all parts of the body on T1 weighted images. It will be hypo or intermediate signal, but it will never be bright on T1 weighted images unless it has a very protein rich area. On the contrary, the T2 weighted images, they are exactly the opposite of T2 weighted images. All the things that were bright on T1, they will be black on T2, and all the things that were black will be bright on T1 weighted images. And you can see here, these are the CSF filled ventricles, the third ventricle, posterior horns of the lateral ventricles, and Sylvian fissures. All the things which are filled with CSF appear white, or you can say hyper intense when you talk in the terms of radiology. On the contrary, you can see that the white matter, the same white matter which was appearing bright on T1 is now appearing dark on T2 weighted images. The gray matter is actually not white as one can say, but it appears whiter compared with the white matter. So you can say it had inverse in its relationship to T1 weighted images. So if to summarize, you look at a CSF, it's dark on T1, hyper intense or white on T2, and the T1 is true to its anatomy. So white matter will be white and gray matter will be gray. That's the amount you need to remember. This is an example of a patient I took from my one of my patient, and I just wanted to show the TR and TE times. As you can see, this is T1 weighted images. You immediately saw that the CSF in the ventricle is black and the white matter is white. On the contrary, on T2 weighted images, you can see the CSF line in a ventricle is bright and the white matter is all relatively black. So it's a T2 weighted images. And you can see the TR and TE times mentioned here. TR time is really short, but again, nobody has time to look at this in a real life. As you can, especially when you can easily recognize the sequences on looking at imaging alone. Now let's talk about T1 offshoots of T1 weighted images. There are very few things things that you will see bright on T1 weighted images. I really want you to take a screenshot of this slide, especially if you're a radiology resident, because it really helps you narrow down the diagnosis when you have a bright T1 spot on the images. There are very few things that have a T1 bright signals. Most of the things have a T2 intermediate or low signals. Most important of these are the fat. These are protein-rich fluid, blood in a special stage. Blood, when the blood decomposes, it gives different signals in different stages. Whenever you see a report of an MRI brain stating a hematoma, it will always have a prefix of hyperacute, acute, early subacute, late subacute, or chronic hemorrhage. Because we can on MRI we can classify the hemorrhage depending upon its appearance. So the part where methemoglobin is present, we will see a bright T1 signals. On the right, you can see midline pericallosal lipoma, which is appearing bright on T1 weighted images. And on this image, in the region of pituitary, these both are armpits, the optic nerves, the temporal horns, the midbrain. In the region of pituitary, you can see there is a hyper-intense cyst. This was a case of craniopharyngioma, which has a high protein-rich cystic component, and the protein-rich fluid also appears hyper on T2 weighted, T1 weighted images. Sorry. This slide is really important for you to memorize, and you can take a screenshot if you want to. The offshoots of T1 weighted images, which we frequently use, are the T1 contrast enhanced images. And sometimes we use subtraction T1 contrast enhanced images. And the T1 contrast enhanced images, as you may assume, all the vessels will be bright and will be contrast, will show contrast, and it will be easy to remember. You can see the CSF is black, the white matter is white, and all the vessels are visible, so it's a T1 contrast analysis. Sometimes, not routinely in MRI of the brain, but in other regions of the body, especially the pelvis and the liver MRI, we routinely perform the subtraction images. What it helps to do, if you have a lesion on T1 plane images, which already has a hyper-intense component, it becomes really difficult to see if there is really an area of enhancement present, or again, that white part is showing without an enhancer. But when you have a subtraction images, it subtracts the whole T1 part of the image, and only the part of the image which shows enhancement will be depicted, and you can easily see the area which has enhanced or post-contrast images. It really helps to decide if the tumor has the recurrence or residual disease, or if the new disease is present. It really is a crucial point to comment on a report. Uh, talk about T2 weighted images. We have an offshoot of T2 weighted images, which is FLAIR. It is very confusing for a newbie to differentiate between FLAIR on and a T1 weighted images. As I've told you, the CSF will be always black on T1 weighted images, and you will first see this image, you'll probably assume that CSF is black is probably T1 weighted images, but you'll have to be a bit more cautious in labeling the T1 weighted images, because the white matter is still black, making it a T2 weighted image. As you can see, this is the white matter. The gray matter is still probably a bit more grayish or whitish compared with the white matter. You can see the white matter tracks are, this is the internal capsule, this is the external capsule. You can see these are still black compared with the uh, uh, gray matter of the body. Why we do flare images? Flare images are really sensitive, and they really help to recognize the lesions which are not normally visible on routine T2 weighted images. It suppresses all the CSF and other bright signals, so all the T2 hyperintense signals which are routinely seen in many diseases, they really stand out, and we can really easily recognize that the chances to miss these lesions are really low. These findings are really important in patients of MS and multiple sclerosis and other demyelinating diseases, where a single spot can make the difference of active disease or inactive disease, and the medication and the management of the patient can change accordingly. So what we look at on T1, T2, and flare images, I have already basically told you, but to summarize again, again, you can take a screenshot of this image. What should we look at on T1? T2. Sorry, can you hear me? My internet connection is a bit lousy at the moment. Let me just change that. if you feel any kind of disruption in my voice or the bad image quality, you can tell me. My internet connection is really slow, so I have to change that. That's if you feel any problem with that, kindly let me know about it, because we are totally living in a void. So, what are kind of different things we can see on T1 and T2 flare images? T2 flare images basically show the same thing, but flare to greater sensitivity than the T2 weighted images. And I already told you there are very limited things that you see on the T1 weighted image, but it shows excellent anatomical details. And anything you see on the T1 flare images, you want to reconfirm back on T1 weighted image about its region or area of involvement. These are the different things you can see: edema, demyelination. When we routinely do an MRI, reporting on MRI brain, we straight go to T2 and flare images, look for anything that's bright that shouldn't be bright, and then we go on next whenever whatever the finding is, I tell you accordingly. Next, really important imaging is the diffusion weighted imaging. It's a very sensitive imaging, but with very poor anatomic details. It's widely used, it's really easier to get, and in many centers it's a part of the stroke protocol because it takes really less time to obtain compared with the other sequences of MRI. We know that it takes 15 to 30 minutes to completely do an MRI of the brain or to clean out all the sequences. But diffusion weighted imaging really takes a very short time, and many specialized stroke centers have a protocol in which they do a CT brain to see for ham, look for any acute I am so sorry. I'm so sorry. I just lost my internet connection again. I'm so sorry. I really have a bad internet connection here. So we were talking about diffusion weighted imaging. Only two kinds of responses you can get on diffusion weighted imaging. On the either it's restriction or facilitation. Either diffusion is not happening or it's happening, but only this information helps in a lot of cases. What happens? We have a certain area in which there are a lot of water molecules which are moving randomly. What we do is we give them a radio frequency pulse. All of these receive a radio frequency pulse. And after some time, we ask them to send back the pulse that we just gave them. If there is normal diffusion, which is also called as facilitation, all the macromolecules will have moved outside of that area, that particular area, and there will be new molecules which have taken up the spot instead. So we won't receive any signals from there. So on DWI images, we will not receive any signal, it will appear dark on DWI. On the other hand, we have some kind of disruption in cell membranes. The pumps ATP, sodium potassium pump, they are broken down due to some kind of cytotoxic injury or tumor or wall effect or abscess. They won't be able to remove the same molecules which were residing inside that cell or area. They will give back the signal, and that will appear bright on DWI images. There's a very simple principle behind these images that we give the radio frequency pulses. If the water molecules are in the same area, their diffusion is restricted. They will give back signal, and they will appear bright. And they have moved out from that area with the normal diffusion present. They won't receive any signal on DWI images, and we'll see the facilitation of the diffusion. These are TWI and ADC images, diffusion weighted and apparent diffusion coefficient images. They are always seen in unison. You won't interpret TWI images alone without seeing an ADC. What ADC is basically a quantifiable map of the TWI of that area. You can actually measure the value of diffusion which has occurred in this area, but it's mainly routine the research purposes, and we mainly rely on the subjective analysis of diffusion restriction, whether it's present or not. As you can see in this area, uh, this is an area on TWI in which the water molecules were unable to move out, and they have given back all the signals, and they are appearing bright on TWI images. The ADC in inverse of these DWI images at the same area will appear dark on ADC images, apparent diffusion coefficient images. Only then you will see that there is diffusion restriction present, and what due to whatever caused it, that will be decided later. Why don't you interpret it alone? I will show you in this example. You have to focus on these three rows or these three columns of the images alone. You can see there was an acute infarct happening. There was active diffusion restriction in this area. This brightened DWI, and then it was black on ADC. Then eventually, when time passed, this is still bright on DWI, but it's also bright on ADC. You can see a tiny spot here. You can if you were looking only at the DWI images, you would have labeled it an acute infarct. This appears hyper on T1, hyper on DWI, and hyper on ADC. If you were looking only on these two images, would have labeled as acute infarct, but what's actually happening is called T2 shine through. It's appearing hyper on all the T2 sequences. Instead of giving as restriction, it's only showing the T2 shine through phenomena. So it's really important that you look at the DWI and ADC at unison and interpret it together. So if you must have seen a lot of physicians and radiologists using the DWI for the stroke, but is it only for the stroke? So that's not the case at all. It has multiple uses, and it helps to differentiate so many different diseases, which they can say pathognomic appearance of a bacterial abscess, epidermoid tumor. The only thing differentiating the epidermoid tumor from an anaclide cyst is the diffusion restriction on MRI. Similar goes for the acute demyelination. Many tumors show, like lymphoma, GBM show diffusion restriction. Some cases of encephalitis and hemorrhage, few stages of hemorrhage, not all stages, also show diffusion restriction. Then comes in the next in the line sequence is the susceptibility weighted images. All you have to remember about these images that these images are the one to see blood and vessels in the brain, abnormal blood and the vessels in the brain. That's it. What happens, the paramagnetic effect is accentuated, and a very small focus appears visible, which might not be visible on other sequences. So any kind of vascular malformation like venoma, like slow flow malformations, like medullary hemangioma, some hemorrhagic infarct, some blood products, some specific focus, they will be readily visible on susceptibility with the images. They look something like this, with the vessels appearing black on all the images. On the right, you can see an example of hypertensive angiopathy. Small areas of bleed are shown in multiple areas, which might not be visible on T2 flare images. Although these are displayed in out of proportion to their size, but you can detect their presence. Here is an example how DWI helps to understand, identify the different vascular lesions. On these T2 weighted images, you can hardly see. This is a focus of cavernoma, which is a hypointense rim and the central hyperintensity. You might miss that when you're looking through many images in a row, but seeing on the SWI images, you can readily identify that there is a lesion. Apart from that, there are also a few other areas which might need another look in the T2 weighted images to see if there is another lesion present or not. On the left, there's a black CSF, white matter, T1 weighted image with the contrast enhanced vessels. You can see there's an abnormal vessel here which should not be present. You might miss that if you're looking through the sequences without any suspicion for that. But on SWI susceptibility weighted images, you can readily identify there's an abnormal structure present here which should not be present normally. And you could go back, you could see, oh, this is a venous anomaly present here, developmental venous anomaly. Sometimes you don't see anything abnormal on other sequences. So the only sequence to show you that there is a developmental venous anomaly DVA on SWI images only. So far we have, to summarize, we have gone through T1 weighted images. We have seen T2 flare. We have seen T1 T-deploy and ADC. We are well aware what we look for on these images. We have seen SWI images. Yes, this is the part we have done so far. And we got already 35 minutes into the presentation. Then come the flow sensitive imaging. Interesting thing about MRI is that it doesn't really need a contrast to see the vessels or flowing fluid. This is an example of MRA and MRV of the brain. Although contrast enhanced MRA and MR venography, MRV can also be done, but you don't really need that. It's really a short time taking procedure, and you can see details. You can go for the contrast on MRA and MRV if you have any suspicion of something unanswered or the pathology is not clear on the images. What it does, it uses the flow of the blood to create the in the time of flight manner images of the different vessels of the brain. These are routinely performed and they have different kind of pathologies to depict. Then a very interesting aspect of MR is MR spectroscopy. Earlier, when we were talking about the physics of the image creation, we talked about the Lamar frequency of hydrogen atoms. The thing is, we know the frequencies of other different components of the body as well. And we can use that to create a map of different molecules in the body. Instead of using radio frequency for hydrogen atoms, we can use it for lipids, we can use for lactate, we can use for an acetylacetic acid, creatinine, choline, and other different substances. What we do is give the radio frequency pulses at these particular their particular radio frequency, and we get back the images, and we can calculate the concentration of these molecules in that particular area, and then we use that concentration to interpret the results. Like in anything which has a high turnover rate, which is undergoing mitotic activity, will have a high choline peak and decreased creatinine. So in tumors, we see high choline and decreased creatinine, which helps us to understand that a particular, we place that voxel at the margins of a tumor and see if the tumor has spread to this area or not. The brain tumors, especially the astrocytomas, they spread along the white matter fibers of the brain. And it is really difficult to exactly tell that what part of the brain is affected and where are the clear margins to detect. This MR spectroscopy really helps. So we place a voxel at the margin of the tumor and we calculate the signals. The voxel which shows that the choline peak has died down means that there is no tumor infiltration in that area. There is no increased cell turnover. The other molecules are depicted on the different diseases like NAA is raised as Canavan disease, which is a demyelinating disease. Lipid and lactate are raised in any kind of abscess, which helps to differentiate it from a metastasis. In brain, metastasis can have a very confusing picture, like a rim enhancement similar to that I've seen in abscess, and these kind of things that help us in differentiating. Then a very important part is the perfusion imaging of the brain. CT perfusion and MR perfusion both are performed to see if what they do is we get the contrast patient and see what we calculate three parameters: blood flow time and blood flow volume to a particular area. For example, you have a patient who has presented to you with an acute infarct of right occipital lobe, and you can see in the DWI image of this patient, the ATC was quite black on these images. This image is a color-coded images for the perfusion imaging, with the red areas are receiving high blood flow, yellow are the receiving lower, and the blue are receiving even lower amount of the blood. In this image, you can see that the I am extremely sorry. I thought we had a premium Zoom and it won't end after 40 minutes, but it did end. So I had to join again. I'm so sorry. We just broke off all my tempo. So we are back again at the perfusion imaging. We were almost done with the MRI of the brain. Really no sense. So I will conclude the MRI part, and I hope that you know what are different MRI sequences and what you will be looking on different sequences when you are presented with a film or on a console if you see it. Let's just talk about for 5 or 10 minutes about the CT images. Uh, Although I know most of you are already familiar how the CT images are created and what kind of different densities are shown there. So I won't go into details of the CT. I just want to tell you that the important part of CT imaging is that it's a offshoot or a very elaborate form of X-ray imaging. We have an source just like here, and X-rays are electromagnetic waves which are projected from a point source, which in case of exit tube, in case of some normal common radiograph. What happens if X-rays pass through the patient and they fall on a X-ray detector, which in case of radiograph is a film, and we see the images. The part which allows the X-rays to pass appears black, like the lungs. They don't really give any kind of hindrance to the passage of X-rays, so they appear black. So on the other hand, bones will be white, that they don't allow to X-rays to pass. This is really important to remember, that because the bone will be always white on CT images. And that's how you differentiate between a CT and MRI on a very beginner level. So now you see image, look for any kind of bone. You can see there, you can see at the vertebral bodies, craniums, anything. If it's put purely white as a sclerotic, it means it's a CT image. X-ray CT differs from the X-ray. Instead of a single detector, we usually have a row of detectors. You must have heard about 64 sites, these were 20 slices machines. What happens is the source, the X-ray in the X-ray tube moves around the patient and creates axial images, which are then reconstructed into sagittal and coronal images. It moves in a helical fashion. That's why it's also called a helical CT. You must have heard the term. It obtains slices and densities. Now, images in the CT depend upon intensity, contrary to the MRI, in which every organ was giving back on own signals. But the image in the CT depend upon the different density of the different tissues, how much they absorb the X-ray and how much they allow to pass. So what happens in the body, that the different soft tissue really don't differ much in their respective densities, soft tissue densities. So we are really unable to identify different structure if we are using it without contrast. This is an image of CT abdomen, because you can say this is a liver, this is kidneys, these are the bowel loops, these are some of the vessels, some are the lymph nodes. We really can't differentiate between these with very clarity, and you can certainly can't identify all the diseases here, and you need the help of a contrast. Same happens with the brain. If you are looking, if you are only looking for a hemorrhage or a fracture, the CT is excellent modality. But if you are looking for multiple sclerosis or demyelinating diseases, or any, you want to characterize the tumors, you need to go for the MRI. Once a friend of mine asked, is CT better than MRI? Uh, so the answer is CT is not better, CT is more feasible, it's more readily available, and in certain conditions, it does the job you need it to do. You don't need to go for an MRI to see for any intraparenchymal hemorrhage the patient has presented to you in the emergency, and you really need to take an immediate decision about it. So what you do is go for a CT brain plane instead of going for an MRI. You don't need to for a very elaborate study in that case. Well, I'm frequently asked about that safety of the CT of different parts of the body and how many chest radiograph it equals. So I found this slide in a book. You can take a screenshot of that, and you can see that a CT brain is equal to 140 chest radiographs. All the radiation goes to the brain, and you have to be very selective about the part of the body you are scanning, and whether a patient really needs that or not. And the other question I am frequently asked is the CT brain is safe for pregnant ladies? So it's completely safe for pregnant females, but you have to use a lead shield on the abdomen. Even you can perform CTKUB given the circumstances and different given the stage of the pregnancy at with if the organogenesis has passed and everything. And one important question I want to ask you people that should we look at the CT films to interpret it? I have seen CT films from different institutions of government hospitals where they only give like 16 or 17 images, and you have to just take a decision about that. Do you guys agree that we should interpret the CT images? We can interpret the CT image in a film, and it's totally okay to do that. Um, you can tell me in the chat probably. So you really don't have an opinion about that. But let me tell you one thing. The answer is that you never ever completely report of CT on a film alone. You can give an opinion, but I would never give you a report or a handwritten report with my science on uh, any CT. Let me show you an example why it's really important not to do that. Um, can you guys screen of this this screen? You can see this is an image of abdomen of a patient. You can see these are the number of images here. There's like 512 images that we will see on this of this patient. When you see only a film of the patient, only 16 or 70 of these 600 images will be presented. Means that you will see only very few slices of the patient, and you will see this area, you will see this area, then you see probably this area. All the pathologies in between these areas will be totally missed. And you will be responsible for that because you have already given the report of being a normal. And second thing is because the CT has different densities, it has like 20,000 shades of gray, uh, uh, and the human eye can only possibly perceive a few. It's really important to adjust the window before seeing CT of any part of the body. For example, you can see if I want to look at the heart, I have selected a different window. But if I want to look at the lungs, I select a different window, and then all the pathology of the lungs will be visible. But the pathology of anything inside the heart will not be visible to me. If I want to look at the bone, I'll have to select a different shade of gray to look at that particular pathology of the window. So in CT, I really want you to know that CT has a limitation, but it's excellent for initial imaging, and in some cases it can be really helpful. And second thing, it's really important to have a reporting having reporting a CT on a console rather than having on a films. There are softwares which are freely available for which are freely available for viewing. For Windows, it's Radiant Viewer, and for iOS, it's the Chorus. You can have that into a laptop. You can ask the patient to bring the DVD with you. Every single private center gives the DVD with study, so you can always see the images yourself. Even if you know the report is there, it will not only build your habit of looking at different images, it will create more of knowledge for you to treat your patient, and you probably will be able to challenge even even challenge the radiologists about its findings. All the great consultants that I have met, urology, of gynecology, of neurosurgery, of general surgery, they actually have quite a fearsome knowledge of different radiology modalities. They really challenge you that there is a report and you are not reporting properly. And they sometimes give you feedback that your report was not up to mark. And you can be that person. And in the end, these are the two articles I really want you to go through because they really after they really give you insight about what is happening in the world and what futures what they're doing in the future with the all the MRI imaging. And that's it for today. Inshallah, I didn't include any pathology on this first lecture because it was already getting really long, and you would be able to retain all of this information in a single image. Next time, inshallah, we will try to talk about stroke imaging. We will start from the very basic imaging, and then we will move on to advanced imaging of the stroke as much as you like. So that's it for today. If you have any question or anything, you can raise hand. I will unmute you and you can ask that. I'll wait for 5 minutes and then everyone will leave meeting. And thank you so much for being. Okay, and someone has asked you why the city films are not enough. I will share my screen again with you. Okay. Can you see the images here? I have opened up a study of a patient. I should actually hide the patient data. You can see there are like in a single study there are 500 to 600 images of a single patient when I'm looking at it. And when I look at the Excel images, there are 600 images that I'm looking through. So whole body of the patient is imaged in 600 slices. What if I take only 16 of these slices? For example, this is a patient lying on the bed, and I randomly select 16 different sizes. I take this slice, I take this slice, and then I so on and so forth, and put these on the images of the film. This is a CT of the KUB. The patient wants to be looked at the ureter. What happens if the stone, this really tiny stone of a 10 millimeter stone, and it lies here? The image will be shown from here, the image will be shown from here, the existing images will be shown. I am drawing the references line on these. This chances I can completely miss the stone which was lying in between these slices. Not only the patient will suffer because of that, I'll have a legal liability because I missed a stone. Someone sees the DVD or whole images, say that your doctor has completely missed a stone. I'll be liable, I'll have a legal liability to that. So that's why you always want to look at at a console to see if you don't miss any pathology. I hope I'm clear to you about this. I think if anyone else have any kind of question or any kind of query, you can ask. Yes, you can ask. I have a question for you, for all of you, that I really want you to answer in the next session, if you remember that. This is a very favorite question of our consultant radiologists that they really like to ask us in the interviews for senior registrar. Actually, I did ask that in the last interview at Services Hospital. Can you see subarachnoid hemorrhage on MRI? You already know that the CT has a very high sensitivity for detection of subarachnoid hemorrhage, like over 90%. But can you see the subarachnoid hemorrhage on MRI, and how does it look like? The answer is actually is in the presentation in one of the articles that I shared at the end. If someone interested, he can find that out. Oh, I should have said that the question is not directed to any consultant neurophysician. Thank you. Go ahead. Thank you so much, Gaurav. That's it for me today. So over to you. Uh, Thank you everyone for being here. It was really pleasant talking to a screen, I guess. Thank you.
Sir, thank you so much for taking time out and having this wonderful session. And I saw that we were 30 strong in the beginning, and unfortunately, when 40 minutes hit, we still had 20 very interested people, and I'm sure they learned a lot. So we thank you again. And if anybody has any questions, they can send to Dr. Mubeen on his WhatsApp. And again, we are very thankful. And everyone will be back again with a new topic next Thursday, inshallah. Thank you. Take care, everyone.